Hi everyone, my name is Dr. Tim Jen, and I'm one of the staff anesthesiologists in St. Paul's Hospital, Vancouver. Today, the talk is titled Regional Anesthetic Adjuncts and Their Roles in Clinical Practice. I have no financial disclosures. Our objectives today are to compare the efficacy and safety of intravenous and perineural dexamethasone and dexmedetomidine, determine their optimal dosages, and summarize the expected durations of sensory and motor blockade and their impacts on rebound pain. Here are our key messages. First, there is a dose-response relationship with ceiling effect for block prolongation for IV and perineural dexamethasone. 8 mg IV or 4 mg perineural dexamethasone seem appropriate for clinical practice. Dexamethasone reduces the probability of rebound pain with an under need of treat of about 3 and reduces postoperative nausea vomiting. IV dexamethasone may be preferred over perineural due to conflicting data on the safety and mechanism of action of perineural dexamethasone. So what happens when you do nerve blocks without adjuvants? Abdullah et al. Conducted a systematic review published in 2015 for patients undergoing shoulder surgery with single-shot interscaling block without adjuvants. And they found that yes, in the first 6 to 8 hours, you do get reduction in pain scores, but this is counteracted with an increase in pain scores at the 16th to 24th hour mark known as rebound pain. Some people might argue that, well, we still save money by discharging them faster. Hamilton et al. Conducted a large retrospective population data study in Ontario from 2009 to 2016 for patients undergoing ambulatory shoulder surgery and found that yes, we can discharge them no problem with decreased unplanned admission with peripheral nerve block, but subsequently more ED visits are secondary to acute pain with peripheral nerve block. And overall, the healthcare cost is slightly higher. So then the question is, at the cost of increased spending and rebound pain, how can we provide optimal acute postoperative pain relief conferred by regional anesthesia? Because after all, patient comfort, satisfaction, and quality of recovery are not captured in large population data. One of the options is to give regional anesthetic adjuncts using an adequate dose via an appropriate route in order to prolong analgesia, reduce rebound pain, and maximize patient safety. So let's get right into it. What is the dose-response relationship of perineural dexamethasone and analgesic duration? Albrecht et al. Conducted a randomized controlled trial and separated patients to 0, 1, 2, 3, or 4 milligrams of perineural dexamethasone. And as you can see from this figure, the duration of analgesia is significantly prolonged with increasing doses of perineural dexamethasone. And Bravo et al. Found that doses of 5 or 8 milligrams beyond these doses do not confer additional block prolongation. How about for IV? Dexmedetomidine et al. Conducted a randomized controlled trial and separated patients into 0, 1.25, 2.5, or 10 milligrams of IV dexamethasone. And they found that, as you can see from the Kaplan-Meier survival curve, higher doses prolong analgesia more than lower doses. And based on subgroup analysis of Cochrane's systematic review published in 2017, the duration of sensory blockade is longer with higher doses of IV dexamethasone, such as 8 to 10 milligrams, when compared with lower doses such as 4 to 5 milligrams. So now we can appreciate that for both perineural and IV, there is some sort of a dose-response relationship. Then which route is better? There's actually some discrepancies in literature, and these are given for illustrative purposes. When you compare perineural dexamethasone with IV dexamethasone at a lower dose, such as 1 milligram or 5 milligrams, you see that perineural dexamethasone seems to do better with a longer duration of analgesia. But when you compare larger doses, such as 8 or 10 milligrams, these differences seem to disappear. So that brings about a possible pattern. We have to keep in mind that each randomized controlled trial compares perineural and IV dexamethasone on a dose-specific basis. And differences may be because the IV dexamethasone dose used is too small, such that its ceiling effect is not yet reached, whereas perineural dexamethasone requires a smaller dose to reach its ceiling effect. In order to elucidate this relationship further, Zafri et al. Conducted a very well done systematic review and model-based network meta-analysis published in the BJA in 2024. It is a very good publication and I encourage everybody to read it. One of the key assumptions of network meta-analysis is called transitivity, which essentially means if A is better than B and B is better than C, then A is better than C. The authors searched from inception to October 2023 randomized controlled trials of adults undergoing surgery with peripheral nerve block with or without general anesthesia, with or without neuraxial anesthesia. They found 118 included studies, of which 22 had low risk of bias. There were 110 comparisons between perineural dexamethasone and control, 31 comparisons between IV dexamethasone and control, 26 comparisons between perineural and IV dexamethasone, and there were several dose-finding studies comparing various doses of perineural dexamethasone against each other and various doses of IV dexamethasone against each other. Zafri et al. Used the collected data to model the dose-response relationship with ceiling effect for duration of analgesia, duration of motor blockade, and postoperative nausea vomiting. The blue curves are for perineural dexamethasone, and the red curves are for IV dexamethasone. The y-axis is the percentage of maximum effect for these outcomes, and the x-axis is the dexamethasone dose used. Dexamethasone showed a maximum increase of 1.67-fold for duration of analgesia, 1.5-fold for duration of motor blockade, and a maximum 0.32-fold decrease in postoperative nausea vomiting. Importantly, the estimated ratio of maximal effect between IV and perineural dexamethasone, otherwise known as the ratio of ceiling effect, were not found to be different, and it was at 0.9. The dashed lines represent the dose of dexamethasone that is required to reach 50% of the maximum effect, and one can envision why at 1 milligram dexamethasone, perineural performs way better than IV dexamethasone in terms of duration of analgesia. Zafri et al., using a Bayesian approach, simulated the outcomes in hypothetical trials to examine the effect of different regimens. The y-axis is the duration of analgesia in number of hours, and the x-axis is the various regimen used. The blue dots represent perineural dexamethasone at 2, 4, 8, or 12 milligrams, and the green dots represent IV dexamethasone at 2, 4, 8, or 12 milligrams. And the black dot is ropivacaine by itself. The bars represent 95% credible intervals. One can see that at 4 milligrams perineural dexamethasone, the duration of sensory blockade is very similar to 8 milligrams of dexamethasone IV. And further increases beyond these doses confer negligible increase in duration of sensory blockade. The authors, therefore, concluded that both routes of administration achieve analgesic equivalency, but perineural dexamethasone has higher potency, and a regimen of perineural dexamethasone 4 milligrams or IV dexamethasone 8 milligrams appear to be appropriate for clinical practice, which I agree with. In terms of rebound pain, Singh et al. Published a systematic review in 2024 and concluded that based on 4 studies, dexamethasone use was associated with significant reduction in rebound pain incidence with an odds ratio of 0.16, which translated to a number needed to treat of 2.8. Examining these trials further, one can see that the doses used were rather large, at 16 or 10 milligrams IV, or 8 or 5 milligrams perineural. So when you compare that with a previous large retrospective study that had a rebound pain incidence of about 50% with a much more modest odds ratio of 0.56, one has to wonder, is there a dose-response relationship between dexamethasone and rebound pain incidence? Based on conference presentations by our colleagues from Dalhousie, dexamethasone might have a dose-dependent effect on rebound pain incidence and severity, and we look forward to their full publication. So here are the key messages again. There's a dose-response relationship with ceiling effect for block prolongation for IV and perineural dexamethasone. 8 milligrams IV or 4 milligrams perineural dexamethasone seem appropriate for clinical practice. Dexamethasone reduces the probability of rebound pain with a number needed to treat about 3, and reduces postoperative nausea and vomiting. Now finally, we will turn our attention to the safety of using dexamethasone as a regional anesthetic adjunct. The higher potency of perineural dexamethasone suggests possible perineural mechanism of action, but the mechanism of action remains unclear. Some people might argue that the prolongation of analgesia might be due to the intrinsic analgesic property of dexamethasone, but that does not really explain the prolongation of motor blockade. So from animal studies, the proposed mechanism of actions include peripheral vasoconstriction, C-fiber inhibition, nitric oxide synthase suppression in the dorsal root ganglion, and from in vitro studies, we found that it does not act directly on the axons. Investigators then hope to elucidate the mechanism of action by conducting volunteer studies utilizing bilateral nerve blocks with perineural dexamethasone on one side and without on the other side, or crossover randomized controlled trials. All trials up till now demonstrated minimal or no sensory blockade prolongation of local anesthetics with dexamethasone use in volunteers, which begs the question, is block prolongation effect of dexamethasone dependent on injury and inflammation? We don't know at this time. In terms of neurotoxicity, there has been conflicting evidence in preclinical histological studies, with results ranging from possible harm to possible protective effect to no effect. So there might be some signal for concern. Is the possible neurotoxicity reflected clinically? There's no evidence of increased neurological complications from randomized controlled trials. However, this is likely underpowered. In terms of observational studies, there had been 2 separate retrospective cohort studies of patients undergoing foot and ankle surgeries with popliteal sciatic nerve block, which show that perineural dexamethasone use is associated with increased neurological complications in one study and increased persistent deficit at 6 months in another study. So there may be some signal for concern. Some people might wonder, well, if I were to give dexamethasone perineurally, perhaps this may decrease the systemic side effects such as hyperglycemia or possible surgical site infection. However, this is likely unsubstantiated, as serum dexamethasone levels are similar after IV or perineural administration. For non-diabetic patients, there is a small and clinically unimportant increase in peak glucose concentration of only about 0.8 millimole per liter. And for diabetic patients, there are some conflicting data with the increase in peak glucose concentration ranging from 0 to 1.8 millimole per liter. So it's not too much. And there has been no impact on wound infection shown with a single dose of perioperative dexamethasone use. So with the last key message, it is that IV dexamethasone may be preferred over perineural due to conflicting data on the safety and mechanism of action of perineural dexamethasone. How about for dexmedetomidine? First, there is a dose-response relationship for block prolongation for IV and perineural dexmedetomidine up to 2 mics per kilogram, but this is limited by side effects with increasing plasma concentration of dexmedetomidine. There is a perineural mechanism of action for block prolongation for dexmedetomidine, and there is no signal for reduction in rebound pain incidence. So let's get right into it. What is the dose-response relationship of perineural dexmedetomidine and analgesic duration? Zhang et al. Conducted a randomized control trial published in 2018, and they separated 100 patients into 0, 1, 1.5, or 2 microgram per kilogram of perineural dexmedetomidine. And as you can see here from the Kaplan-Meier survival curve, higher doses are associated with prolonged analgesia duration, but at the expense of increased hypotension and increased bradycardia. How about for intravenous? Kang et al. Conducted a very similar randomized controlled trial for patients undergoing arthroscopic shoulder surgery and separated patients into 0, 0.5, 1, or 2 microgram per kilogram of IV dexmedetomidine. And as you can see here, the higher doses are associated with prolonged duration of analgesia, but also at the expense of increased hypotension and with the resultant increased ephedrine use. We can appreciate that dexmedetomidine side effects are correlated with its plasma concentration, the main side effects being hemodynamic changes and sedation. Notably, one can appreciate a biphasic response in blood pressure with hypo then hypertension, as dexmedetomidine loses its alpha-2 selectivity at higher concentrations. And with higher concentration, there is also increase in sedation. The plasma concentration of dexmedetomidine with a brachial plexus block with a perineural injection of 2 mic per kilogram, which is signified by the red dots here, is perhaps somewhere between 1 to 2 mic per kilogram of IV infusion over 10 minutes. Now, the limitation of the data here is that these are from 2 separate studies. Therefore, the key message is that there is a dose-response relationship for block prolongation for IV and perineural dexmedetomidine up to 2 mic per kilogram, but this is limited by side effects with increasing plasma concentration of dexmedetomidine. Preclinical animal studies have shown that dexmedetomidine acts peripherally and perineurally to improve local anesthetic action through the blockade of hyperpolarization activated cation current, as opposed to acting on the alpha-2 receptors. Subsequently, volunteer studies with bilateral concurrent nerve blocks showed prolonged blockade in the limb with perineural dexmedetomidine compared to the limb without, which also support a perineural mechanism of action. When comparing perineural versus IV dexmedetomidine, all the trials seem to favor perineural dexmedetomidine in terms of duration of sensory blockade, motor blockade, and analgesia, and the onset of sensory and motor blockade. Notably, in this systematic review, no meta-analysis was conducted due to a high heterogeneity of trials. In terms of neurotoxicity, most preclinical studies showed neutral or protective effects even at high concentrations. However, there were signals of harm in 2 studies. One is at the highest studied concentration in rabbits, and the other one was in rats with diabetic peripheral neuropathy. In clinical studies, based on a systematic review, there were no signals of harm, although this is likely underpowered because it only involves 7 randomized control trials. Therefore, our second key message is that there is a perineural mechanism of action for block prolongation for dexmedetomidine. And finally, in terms of rebound pain, currently, based on 3 small randomized control trials, there's no signal for benefit for rebound pain associated with the use of dexmedetomidine. And that is our last key message. Thank you very much for listening. I hope you have a great day, and don't forget to smash the like and subscribe button for more high-quality regional anesthesia contents.